Good morning or good afternoon, everyone, depending on where you are joining from. My name is Susan Cosgrove. I am the Senior Director of Community Impact at Healthcare Improvement Foundation, and I'm here today to share what we've been able to accomplish in Pennsylvania over the last 13 years, growing a 5-county regional collaborative into a statewide coalition with continuous grant funding from the Pennsylvania Department of Health. So I want to start my presentation today by sharing a little story. So early on in this work, I attended a panel at a health literacy conference. It might have even been this one several years ago. And one of the speakers shared an idea that stuck with me. They described partnering with local pizzerias to stick open enrollment information on the tops of pizza boxes to spread the word to the public about open enrollment. So this was, I think, in the early days of the Affordable Care Act, when open enrollment was just launching. And I was just sort of in awe of the simplicity of this idea and the ingenuity as a way to spread health information to the public and to meet people where they are. And I think about this often in my own work and find myself reflecting on our own pizza box strategies. So those unexpected or innovative tactics that have that potential to elicit an aha moment in our partners or our audiences. And I hope that at the end of this presentation, you find yourself with at least one pizza box strategy that you can take back to your own work that inspires an aha moment for you. So in my presentation today, I will start by providing context about my organization, the Healthcare Improvement Foundation, and the Commonwealth of Pennsylvania, followed by an overview of our health literacy initiatives and how they've evolved since we began this work in 2010. From there, I'll highlight some of our key challenges and successes through the years, and then close on our aspirations for the future and key takeaways. So Healthcare Improvement Foundation, or HCIF, is a Philly-based nonprofit organization that works with clinical and community-based partners to improve healthcare. We use skills in program design, coaching, facilitation, measurement, and evaluation to convene stakeholders and achieve common goals. Health systems, insurance plans, government agencies, foundations, businesses, and healthcare associations collaborate with us and provide us with both general and targeted funding. And historically, our primary partners have been hospitals and health systems, but we're increasingly working closely with community-based organizations and other institutions to advance our goals and agenda. We recently revisited our vision and mission and updated them in 2021. And so you see here that we have a greater focus on increasing equity, accessibility, and quality throughout all of our programs. We operate under 2 guiding frameworks, clinical quality and patient safety, and population and community health. And even within these 2 frameworks, we take very similar approaches as I described earlier. And one question that we often get asked, and I think that anybody who works in the health literacy field gets asked, is where does health literacy live within your organization? And while health literacy could easily fit under either of these pillars, within HCIF, health literacy lives within our population health portfolio. Other programs in this portfolio focus on community health needs assessment and improvement, and chronic disease prevention and management. And our health literacy initiatives are supported by a team of 5 staff members. We devote approximately 1.0 to 1.5 FTEs to the health literacy activities and efforts that I'm about to describe. And we're also supported by a large network of partners that you'll hear more about, and by consultants who provide subject matter expertise and additional program support. So I think some of my team members are participating in this session. Just want to say thank you to our team. So what do you think of when you think of Pennsylvania? I want to highlight a few features of the Commonwealth that have informed our work over the years. And I will start with this slide. So Pennsylvania is the 5th most populous state overall. We have a population of approximately 13 million. We are known for many things, including our passion for our sports teams on both sides of the state and everywhere in between. They're gregarious mascots. You can see Gritty in the bottom corner of the state, the Flyers mascot. We're also known for our various signature food items, ranging from cheesesteak to Hershey's bars, pierogies, shoe fly pie, our interstate feuds, Wawa versus Sheetz, U's versus Yins, and being the home of many a popular sitcom like The Office, which takes place in Scranton in the northeast corner of the state, and Abbott Elementary, which takes place in Philadelphia. And just for context, that is my oldest child showing off his Steelers pride in the western region of the state. The Center for Rural Pennsylvania identifies counties in the state as being either rural or urban based on their population density. I believe the cutoff is 291 people per square mile. Pennsylvania has 67 counties. 48 of them are rural counties. They are depicted in green on this map, and 19 are urban counties depicted in gray. So the urban counties center primarily around the southeast region of the state. So you have Philadelphia as the population center there, sort of creeping into the central region of the state where you have Lancaster, Harrisburg, Hershey. We have Scranton as one of our population centers in the northeast region of the state, Erie in the northwest corner, and then Pittsburgh in Allegheny County in the southwest region of the state. So in 2020, nearly 3.4 million people, or 26% of Pennsylvania's population, called the rural counties home, with the rest of the population dwelling in our urban counties. And when you compare that rural-urban map of Pennsylvania to the county health rankings map, you do see a mix of urban and rural counties across all quartiles. So on this map, the lighter shades of teal represent a higher or better health rankings in the county health rankings. And a few other things that I think are worth noting as we think about the health of Pennsylvania as a whole. Much of Western Pennsylvania and even Central Pennsylvania is situated in Appalachia, which is a region of the country that's historically associated with longstanding discrimination and disinvestment, which results in less infrastructure and fewer economic opportunities for its residents. In the southeastern region of the state, you can see the disparity between Philadelphia, which is frequently ranked low to last on many of our health measures, and its surrounding suburban counties, which hover at the top of the rankings. And here, we see racial disparities that cut more across racial and demographic lines. So, we see disparities across the state manifesting in different ways for different reasons. I'm going to come back to all this context. Just wanted to lay a little bit of a foundation, about Pennsylvania if you're not familiar, and we'll talk later about how some of this has informed our work or created challenges or opportunities for us to do statewide health literacy work. So what do our health literacy initiatives look like in Pennsylvania? I'm going to start by providing just a very brief overview of our program and then go into more detail as I describe how our work has changed over time. So I always start by stating that our work is grant funded and just noting how lucky we are to have funding from the State Department of Health and to have them willing to invest in this work long term. I know that many health literacy coalitions get up and running without any funding at all. And so we are also, I think, unique in this and having that investment from the state. So we began this work in 2010 with a limited regional approach in the 5-county Philadelphia region, so Philadelphia and its 4 surrounding suburban counties. And then it was around 2014, so 3 or 4 years into this work, that we expanded into a statewide focus at the request of DOH. And the foundation of our work is training and education. We enhance that with shared learning opportunities for our partners and for other health literacy champions across the state. And then upon that, we build technical assistance and support for organizational change. And then beyond that, we have broader coalition building activities to engage a diverse set of stakeholders in Pennsylvania. And I'll talk more about each of these components in a little bit. So how do we know what we are doing is working? We track a number of process metrics to demonstrate the reach and effectiveness of programming. So we look at the number of participants in our trainings and events, the number that we reach via our mailing list. We look at satisfaction of every training, event, webinar that we hold. So we ask participants to rate the quality of the events, training sessions, the quality of the tech and the delivery method. We look at behavior change, particularly when it comes to training and education. So we ask participants if they intend to change practice, and if so, what practices they intend to change or what new practices they intend to adopt as a result of receiving education related to health literacy. We also track knowledge gain by administering pre and post tests for our training sessions. And then we track organizational change by asking our partners to report the interventions over the grant year and any policies that they have adopted related to health literacy, as well as their priorities related to health literacy and health equity as well. So due to our lack of direct access to patients, it is really challenging for us to measure outcomes. The Department of Health has supported these efforts in several ways, including advocating for the periodic inclusion of the health literacy specific module in the Behavioral Risk Factor Surveillance System, or BRIFIS. And that has been included in Pennsylvania's BRIFIS, I think 2 or 3 times over the last several years. So about every 2 to 3 years, we see those measures included. We also work very closely with our clinical partners to assess additional opportunities for outcomes assessment. But this is something that I think is really challenging for us to figure out how to report on. So in over a decade of our work, what has remained constant and what has changed? So as previously mentioned, our health literacy work is funded by a Preventive Health and Health Services Block Grant by the CDC through the Pennsylvania Department of Health. And for the duration of this grant, HCIF has served as the sole grantee for health literacy services in Pennsylvania, a member of the grant management and leadership team, and the primary grant and project manager. So the original request for proposals came to us by way of faculty members at Thomas Jefferson University, and our partners at Jefferson served as principal investigator, subject matter experts, evaluators, and steering committee members for the first 10 years of the grant up until a few key faculty retirements a few years ago. And 2 of our emeritus steering committee members and my health literacy mentors, Dr. Ricky Brower and Dr. Jim Plum, continue to support these efforts as trainers and as subject matter experts, even though we no longer have that sustained partnership with Jefferson as an academic institution. And part of what has allowed us to move kind of in a different direction is that we've been building up HCIF's own internal capacity as subject matter experts around health literacy and building our capacity as an organization to also serve as trainers or to serve as evaluators of this work. We've built this subject matter expertise drawing on a number of resources. So they include our own training materials that we've developed, obviously mentorship through our subject matter experts, conference attendance at conferences like this or other health literacy conferences with a nationwide audience. We've had several staff members pursue the health literacy specialist certificate through IHA and found that to be incredibly helpful. And again, just constantly seeking these opportunities to build staff facility around health literacy to help improve capacity within our organization. So another key partner in our statewide work has been the Center for Healthcare Solutions. They were formerly known as the Healthcare Council of Western Pennsylvania, underwent a name change last fall. So if either of those names sounds familiar to anybody in the audience, they're the same entity. And they are located in the greater Pittsburgh region. So while HCIF was launching our regional health literacy activities in southeastern Pennsylvania, the folks at the Center for Healthcare Solutions were launching what they called the Regional Health Literacy Coalition, or RHLC, which served as a regional coalition to address health literacy in the southwestern Pittsburgh area of the state. Just really interesting to see kind of both of those coalitions bubble up organically in parallel and sort of complementary to one another along the same timeline. So when we were asked to expand across the state, we knew that they would be a great partner for us to work with. And the Center for Healthcare Solutions has served to expand our training capacity, our ability to fulfill requests in western and rural regions of Pennsylvania, and has also been at the helm for sort of several special projects, including a teens guide to transitioning from pediatric to sort of family or internal medicine and taking control and ownership of your healthcare, as well as a few other projects related to immigrant and refugee health literacy too. And over the years, we've explored additional models for diversifying the grant leadership with varying degrees of success. So When we started this work, we originally envisioned maybe a regional hub model, and we encountered challenges in identifying the right organizations and individuals to lead efforts in other regions of the state. And I think what I would like to note too is that there have always been lots of pockets of activity, centered on a single organization or maybe a couple of organizations working together to advance health literacy in Pennsylvania. That's always been happening. And so I think, the goal has always been to sort of align all of those efforts under this umbrella of the Pennsylvania Health Literacy Coalition. Sort of when we moved on from the idea of regional hubs, we attempted to identify a committee through nomination, through self or others, but didn't quite get the uptake we were hoping for. And then, last year we moved towards a health literacy champions network focused on individual and organizational capacity expansion. That group has been in a little bit dormant, but will reconvene this summer. And I think one of the key things that we have struggled with a little bit here is that because we have a grant from the Pennsylvania Department of Health, we already have sort of our work statement, we have our activities, we have our work cut out for us. And so that's where we have always tried to seek out what is the best meaningful way to engage folks throughout the state in this work, if we sort of already have our objectives laid out for us. And I think that's where, this idea of a champions network, where we can really engage folks who are committed to advancing their own health literacy skills and health literacy within their organization and sort of advancing leadership within health literacy that way. I think that's where that is going to be a really nice model for us going forward. And so an aspect of our work that has been sort of the most successful has always been our use of a collaborative model for shared learning across our partners, and supporting that model with modest partner payments supporting organizational health literacy efforts. We provide these payments annually to our clinical and community-based partners, and they're intended to support staff time and development for our project leads, as well as provide a small amount of discretionary funding to support the health literacy priorities of each organizational partner. Again, these are not large grants. They are a few $1,000s per partner. And again, I recognize just how unique and lucky we are to have a pot of funding that we can draw from to support these efforts within our organizations. You can still do the coalition work, the collaborative work, the shared learning without that funding. But because we have funding, it's very important to us that we share that with the partners that we are asking to do the work. I think it helps us with buy-in. It helps ensure that our partners have some kind of skin in the game. It helps us with evaluation and reporting back up to our funder. And again, funding is not necessary to do this work, but I do think it's a strength of our programming, and sharing that funding is something that really aligns with our values and the way that we want to do our work. So throughout the duration of our work, we fostered formal partnerships. So these are partners that receive funding from us through the grant with several different types of organizations. We have clinical partners. We've worked with senior centers. We work with community-based organizations that serve immigrants and refugees. And we have a statewide training partner. And that's in addition to sort of the academic partner and the other statewide partner that I mentioned earlier, Jefferson and the Center for Healthcare Solutions. And then in addition to these formal partners through our coalition work, we've engaged dozens of organizations in more informal partnership. And it's been really rewarding to watch these partner networks change and grow over time. To take the example of our clinical partners specifically, when we initially engaged these partners at the start of the grant, when we would have events for them or sort of have networking calls, I feel like we would have to develop sort of very detailed agendas. We would have to do a lot of facilitation. And now just seeing these partners develop relationships over the years, they are able to reach out to one another without us serving as sort of the mediator, which I think is always our goal, is that our partners can work with and through one another in addition to working with and through us. And so as we've watched, these relationships blossom, we welcomed new representatives to the group as project leads change or as we see turnover, and, have seen kind of the way that new project leads are able to assimilate very quickly with that peer support and learn from one another as well. And a great example of the way that some of these partners have blossomed is the development of the Immigrant Health Literacy Initiative, or IHLI, and hospital partnership. So up until a few years ago, we were convening our partners sort of more individually. So we would get our clinical partners together, we would get our senior serving partners together, we would get our IHLI partners together. And we were sort of continually grasping for ways to foster sharing across our different partner groups. And so with feedback from our IHLI partners in around 2017, we shifted the programming that we were delivering for them and moved into this model of partnership with our hospital partners. So what we heard from them was that what they really wanted was an ability to make a connection with some of the clinical organizations that their clients were going to. They indicated that whether it was a success story or a challenge that was encountered, through hospitals and health systems, that bridge didn't exist. There was a gap in communication where the community-based organizations, were not able to kind of break through or didn't know who they could reach out to at the hospitals to have a strong contact there. And so this is where we decided to convene our clinical partners, I think exclusively hospitals that were Philadelphia-based, with our IHLI partners, also Philadelphia-based, for the Immigrant Health Literacy Initiative and Hospital Partnership. And so this was a group that met every other month to a quarterly basis and could really talk about a lot of the challenges that immigrant and refugee communities were facing. Hospital representatives, many of whom were in patient experience, could sort of hear directly from folks on the ground who were doing more grassroots work about those challenges, and then work together to come up with solutions or more opportunities for collaboration to better serve those populations. And the work of this group was really foundational to the inclusion of immigrant and refugee voice in a subsequent regional community health needs assessment that was completed in 2022. So moving on, I'm going to speak to how our areas of focus have evolved over time. So our grant objectives have always been roughly the same. We want to address health literacy on both sides of a healthcare encounter by training providers, fostering organizational changes, and empowering patients and consumers. And even as we've continued to advance these objectives, our focus has also shifted and changed over time. So we initially began with a focus on cardiovascular health in adults age 50 and older. This was the population of focus for the additional request for proposals and remained our focus for the first 3 years of the grant. With the mandate from the Department of Health to expand activities statewide came a more general focus on health promotion for all. So not limited by age, not limited by medical condition, just thinking more broadly around health literacy and health promotion. And that focus on cardiovascular health, that resulted also in an initial focus on hospital settings specifically and inpatient settings, cardiovascular units primarily. So with our broader focus, we have been able to expand our clinical partnerships to include outpatient settings like clinics and accountable care organizations, and expand our partnerships to encompass more community-based partners to reach patients and providers wherever health happens. And then finally, our initial focus was more on patient experience and quality of communication in clinical settings. So early in this work, we asked our hospital partners to share their Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAHPS, scores from their cardiovascular units as a way of evaluating if our health literacy activities were resulting in any shift in those scores in the communication-related metrics specifically. So for several reasons, we did not find this to be a highly effective form of evaluation. So that included the fact that it was hard to disaggregate those HCAHPS scores to just one unit. And we also, when we were able to do that, we ended up with very small Ns. But I raised that, as an indication of how we were trying to think about and operationalize the impact of our work. Again, looking at it through that patient experience lens of kind of what is happening, again, specifically in inpatient hospital settings. So since then, we've shifted to focus less on patient experience and more on how health literacy is critical for addressing health equity and reducing disparities. And our current work statement explicitly includes the embedding of equity and anti-racism in our work as we continue to seek opportunities to make these connections. Just as the HCAHPS scores were not the key to unlocking, the the success or effectiveness of our initiatives. I think we're also struggling to figure out, like, how do we evaluate now that we're working more in this equity space? What are we looking at to kind of demonstrate that? But I think nonetheless, this is the direction that we feel strongly that we want to go in. So as I previously mentioned, training and education is truly the foundation of our work. And it's really the success of our training that gave us the opportunity to expand from a regional coalition to a statewide coalition. So we offer training for health professionals in the form of a train the trainer curriculum that remains rooted in the American Medical Association's health literacy education for providers. And we previously offered a peer education training for seniors that utilizes IHI's Ask Me 3. The peer education training ended in 2020. I'll speak to that a little bit more later in this presentation. So for now, I'm going to focus more on our provider training. So throughout the years, we've tried many different formats to make provider training accessible. And if there is one thing we've learned, I think it's that there's no single most effective format, and that it's important to be able to be adaptable and to be able to deliver tailored training based on the needs of your audience in terms of the amount of time they're able to commit, their preferred delivery format, whether in person or virtual or hybrid, and the topics that are most relevant to them. So we initially delivered our content as 3 half-day in-person sessions. And what we saw was that we were missing folks. So we weren't getting exactly the same attendees across all 3 sessions. And so we would have a number of people who would sort of get pieces of it, but not get kind of the whole picture. So we later compiled those half-day sessions into a single full-day in-person training session, which, again, I recognize is not something that is accessible to everybody, but the people that we had in the room, they would get kind of the full gamut of the health literacy training. So the basics, health literacy 101, what the research says, techniques for oral communication, written materials development and design, and then some special topics related to accessibility, digital design, and things like that. So the pandemic is really what kicked us, and I know many other organizations, into high gear when it came to being able to deliver live virtual in-person trainings via Zoom. So we've been doing this for the last 3 years virtually. I think many of the limitations are known, including the fact that we're not going to have an all-day virtual training. Those are shorter training sessions. They tend to be more targeted and cover only a couple of topics that are most relevant to the audience. But generally, we have found that to be a pretty effective way to deliver training as well. And then finally, we do have self-directed online training modules available that we actually began developing prior to the pandemic and just recently completed. And overall, we obviously fulfill training requests for the partners that we work closely with. We also field a number of training requests that come from organizations statewide. Some of this come to us by way of our program officer at DOH. And we attempt to fulfill all of our training requests either ourselves or by engaging a partner to fulfill those, and again, to provide tailored content based on the needs of the organization. And so this can range from 1-hour grand rounds presentations. We've done materials design and review trainings for marketing teams specifically, or general trainings for complex care teams that are exclusive of staff of all levels within the organization. The last component of our work that I want to highlight here is our approach to supporting organizational change within our partners and our clinical partners specifically. So in addition to providing training and education, we assist our partners with identifying health literacy champions within their organizations that can help advance the work. So this includes, C-suite level folks, really engaged physicians, just thinking about who it is within your organization has the interest, has the capacity, and frankly has sort of the power or the sway to take on health literacy and elevate it for the organization. In addition, we assist our partners with identifying their targeted priorities. This can include, for example, improving the materials design and review process, implementing new discharge folders, adding health literacy competencies to mandatory staff training. So we sort of assist with the brainstorming phase with thinking about what priorities our organization might want to take on, and then help track progress through quarterly networking calls and annual formal reporting. And the 10 attributes of health literate healthcare organizations, I think, a lot of you are probably familiar with this position paper. It was released, I believe, in 2012, so pretty early in our work. And we later adopted this framework as the model we use to track organizational change. So we took our annual reporting template and structured it around the 10 attributes and asked each of our clinical partners to report their activities under these rough kind of buckets. We used this framework up until 2020 and found it to be really useful to look at where we had kind of clusters of activities from our partners. For example, we had a lot of activities around materials review and design, a lot of activities around kind of staff training, and also where those gaps were. So where we were not seeing as many initiatives. And so I would say for us, certainly the final attribute around sort of insurance coverage, explaining coverage and cost, we did not see a lot of activity. So we did find this to be a really helpful framework. And we used this up until 2020. And in 2020, essentially what happened is that we just wanted to streamline our reporting process to ease the requirements on our clinical partners who were overburdened at the time by the pandemic. So moving on, I want to reflect on some of our challenges and our successes over the years. So I want to call back to some of the attributes of Pennsylvania that I highlighted earlier in the presentation. So Pennsylvania is a big and diverse state, and creating a coalition that meets the needs of all providers, of all organizations, and all of our citizens and residents has been very challenging. Even as I spoke to how we see health disparities in all regions of the state, the causes behind those disparities are different a lot of the time. And so it has been challenging for us to figure out how do we develop a coalition model where we can reach remote areas of the state while also attending appropriately to the more populous regions of the state where 75% of the residents live. We've also had to balance how we expand, when, why, where. So do we expand the breadth of our services, for example, by expanding our geographic footprint? That was sort of the first way in which we expanded from a regional coalition to a statewide coalition, was saying, hey, we're going to deliver this training in other regions of the state. We're going to deliver trainings in central Pennsylvania, northeast Pennsylvania, southwest Pennsylvania. Versus considering the depth of services that we're offering through this programming. So how are we continuing to grow and meet the needs of our existing partners that are more regionally concentrated, but might be kind of further along in their health literacy work? So for example, do we devote time to developing additional advanced training modules for partners who have been engaged for a long time? How do we balance that? I think we are constantly trying to balance that and sort of reevaluating depth versus breadth. And figuring out the best way to try to be effective in that. And honestly, the most effective way we found to address some of these challenges, again, comes back to making sure that we're engaging the right partners, particularly those whose expertise and reach complement ours, and those that might have more familiarity with rural regions of the state or other regions of the state. So the next challenge that I want to highlight to kind of come back to some of our organizational challenges and some of the challenges that our clinical partners have faced specifically. And I want to start by saying that these are not specific to Pennsylvania. I think these are challenges that you will hear about from many other entities and organizations, even this week at this conference. And I think the greatest challenge is simply the breadth of culture change enacted throughout every level of an organization that is required to see sustainable and lasting gains in addressing health literacy. So alongside that, how do you maintain sufficient momentum to create that broad change within institutions, and particularly within healthcare institutions, where we know that there is always turnover, and I think over the last few years in particular, there's been a very high rate of staff turnover at these organizations. These are challenges that we continually grapple with our partners. I think these are challenges that come up during our networking calls, through those shared learning venues. And I think that we are really still, working through a lot of these and, sometimes sort of taking 2 steps forward, 1 step back with our partners. And then finally, I just want to highlight some of the challenges that we've encountered recently, really over the last 3 years that are related to the pandemic. And the biggest challenge that we have seen has really been around our partners' capacity to participate in our collaborative activities, and to focus on health literacy initiatives as well. So I think I alluded to the capacity challenge faced by our clinical partners, in terms of staff turnover, staffing ratios, just being stretched so thin by the burdens of clinical organizations, especially hospitals, that arose with the pandemic. And we also saw capacity challenges faced by our community-based partners and our IHLI, or our immigrant and refugee serving partners in particular. So we saw their capacity to participate in activities diminish as they scaled up their capacity in other areas. So they were scaling up to meet the pressing social needs of the communities they served, which I think very clearly had to be the priority because that need was there in that moment. But obviously that diminished, that capacity has to come from somewhere. And it did result in decreased capacity to participate in things like collaborative meetings or networking calls or things like that. Several of our partners were unable to sort of sustain their specific activities. Again, many of our clinical partners had to pivot. And this led to the sunsetting of our peer education program for seniors, which I mentioned earlier. That program came to an end in 2020. Senior centers in Philadelphia were closed for a very long time. They slowly reopened, sort of more with like drop-bys, rather than sort of a full reopening. And that was a piece of our programming that we just were not able to figure out how we could deliver it effectively through a virtual platform. And then finally, we just saw an overall decrease in the requests for training that we received statewide. So as I mentioned, we offer training for our partners, and then we also field requests from essentially any organization in Pennsylvania that is interested in receiving health literacy training. And we just were not receiving those requests. I think this is not surprising, again, that this was not kind of staff training, professional development was not necessarily an area of focus over the last 3 years. But all that being said, to move into some of our successes, and I'll start with some of our successes specifically related to the pandemic, it did create opportunities for us and for our partners to test the health literacy infrastructure that they have been building for years. So some of these successes include, as I mentioned, for us, really getting our virtual training formats off the ground, and seeing increased reach there. So, being able to deliver webinars, trainings, summits, meetings, events, all of our programming fully virtually. This has allowed us to reach more people in more counties and zip codes than we were previously able to with in-person events. For our partners, I think what we saw is sort of an immediate recognition of the unique and urgent health literacy and health communication needs and opportunities presented by the pandemic. And even if they were not able to sort of advance our health literacy activities and initiatives, we really saw them, take on health literacy like through the lens of the pandemic, through the activities that they were undertaking. And again, just being able to be responsive to some of those unique and urgent health literacy and health communication challenges. We also saw sort of continued opportunities for enhanced or new partnerships. For example, for us or through our partner organizations to engage through like local public health efforts, communications, and organizing to advance the pandemic response. So again, I like to think that on some level, kind of all of the health literacy training that we had done kind of up to 2020 did help prepare our partners for some of the challenges that arose in that moment. And so to give you a sense of our reach, so to date, we and our partners have trained over 23,000 providers statewide in Pennsylvania. We've delivered peer education to more than 1,500 community members. And we currently reach about 700 coalition members on a regular basis through targeted communications on our mailing list. And that number sort of continues to grow. And then of all the maps in this presentation, this is the one that I am most proud of. So orange indicates counties where we've had participants in training sessions or events during this work. To date, our trainings and events have reached Pennsylvanians in more than half of our 67 counties. And, we're just really happy with the distribution through rural and urban regions of the state. And again, I think this is where we see that impact of delivering virtual programming. We will have to think really hard about whether we want to go back to in-person. We have seen diversification of the zip codes in the counties represented. We have seen a greater number of participants in our sessions when they are virtual and therefore accessible to people where they are at in the state. And then finally, we truly owe our success to our partners who are on the ground doing this work. And I want to highlight some of their accomplishments. So our clinical partners have implemented health literacy interventions such as incorporating health literacy principles into staff orientation or mandatory competencies. I mentioned that staff training is a focus. I think every single one of our partners has had some accomplishment or intervention related to staff training over the years. We've seen improvements to the discharge process, for example, materials revisions or the development of folders or binders to help patients organize their information. And with the improvement to the discharge process, this is an example where one partner kind of developed this great discharge folder, and then they were able to share it with the other partners who were able to sort of follow that path as well. So a really nice opportunity for shared learning there. And then I mentioned updates to patient education materials as being something that we've seen across all partners. We're seeing attention to policies, process, what happens when a new material is developed, who is looking at it, how can we increase capacity so it's not just one person or the single chair of the Patient and Family Education Committee that has kind of all materials through the organization funneled to them, how to make that more robust. I would say most of our clinical partners have worked on that. And then just additional adoption of policies or procedures that promote or advance health literacy within the organization. For our senior centers, again, this is a part of our programming that we sunsetted a few years ago, but I do want to highlight the success of their peer educator programs. We asked our senior centers to continue to identify and recruit their most engaged community leaders during this program. And it was really rewarding, again, to hear participants share their newfound comfort with asking questions of their providers, something that was really difficult for many of them prior to attending the training and prior to hearing from one of their peers, someone in their community that they knew and respected, like say to them, oh, it's okay to ask questions. It's good to ask questions when you are engaging with your healthcare provider. For our Immigrant Health Literacy Initiative partners, we've seen a lot of activity here, I think particularly over the last 3 years, and they've implemented health literacy interventions, such as navigation of patients to health and social services. We did a data collection project with those partners where we situated interns within each partner to sort of look at their data to try to look at what is the scope of like navigation and health literacy adjacent services that they're offering to clients that may be sort of going under-recognized or underappreciated. They also have undertaken translation and interpretation support during medical encounters, dissemination of patient education materials in multiple languages, including COVID-19 health communications. And then, as I previously mentioned, providing data and community feedback for the 2022 Community Health Needs Assessment that supported more than 25 Southeastern Pennsylvania hospitals in doing their mandated Community Health Needs Assessment. And then finally, I want to recognize our statewide training partner, the Pennsylvania Patient Safety Authority. This is another partner where we were not able to continue working with them through the pandemic for a number of reasons and challenges that we encountered, but they were instrumental in increasing our training reach throughout the state. And they did this by training all of their patient safety liaisons, who I believe cover different regions of the state. We educated them as health literacy trainers early in our work, and this was an incredibly effective model for increasing reach, and PSA alone has provided training to several thousand providers on site in hospitals, ambulatory surgical centers, and clinics all throughout the state. I mean, they are everywhere on that map that I showed. So really just want to recognize them as being a really effective training partner for much of this grant. So finally, what do we hope to accomplish in the future, and what are our key takeaways for this work? So we did undertake a strategic planning process in 2020 and identify the need for a future focus on embedding of health equity and anti-racism into our programming, looking at diversity, equity, inclusion, looking at that and the intersection with health literacy and how we can advance both together. How can we update our training materials to reflect this relationship and keep this focus in mind? How can we explore opportunities to support kind of cultural and linguistic access and enhance our relationship with our IHLI partners? And then, as I've mentioned, how do we think about growth? How do we think about balancing the depth of our current programming, growing with some of our partners, while also expanding that geographic reach and acknowledging that there are still people in Pennsylvania that we haven't reached where we can build awareness? We have a little more than 1 year left on our current grant, so I think it's also really important for us to be thinking about sustainability. So what does this model look like beyond our current funding period? We're also thinking a lot about health literacy in a digital world, what it means to navigate electronic health records and patient portals, digital accessibility and equity as well. And then how do we continue to identify new venues and partners for this work? And who are some of the key partners that we are not reaching that we could engage in the future? So if I had to sum up our key takeaways in 5 points, they are here, and I would say our whole team sort of contributed to these. So the baseline awareness of health literacy, it continues to grow. We've seen it growing over the past few decades. But there are always new audiences that benefit from training and education. There's always more outreach you can do. There's always more awareness that you can build. That demand for training, I think, will always be there. Organizational change happens in fits and starts, and you really can't get discouraged by a 2 steps forward, 1 step back approach. We've seen organizations make great strides, and then their project lead leaves, and like that turnover results in some stalling of the program. I described kind of how the pandemic affected this. Slow and steady, I think, is really the way to go here, and take the progress as you can. Health literacy and health equity are inextricably linked, and now is the time to make the case for both. There's so much attention on equity, diversity, and inclusion, and I just think the linkage between that and health literacy is so important, and I think there's a really strong case to be made for health literacy under the umbrella of some of the DEI initiatives that we're seeing with our partners. No single organization can address health literacy alone. So as I've described kind of the different partners that we have had, I recognize that we're still only working with a small set of partner groups in the state and a limited number of sectors. It truly does take a multi-sector coalition of clinical and community-based partners to meet this need. And again, going back to that first point, there's always room to grow that coalition in this work. And then finally, building truly transformational rather than transactional partnerships is an ongoing process. It takes significant time and effort, but it really is time well spent. As I've described, one of the most rewarding parts of this work has been witnessing the growth of those partnerships over the past decade plus. And again, just finding the capacity to move from transactional relationships to truly transformational relationships and building that coalition around those principles. So I just want to close today by highlighting, there's another session that might be of interest to you if you want to hear more about statewide health literacy coalitions. I believe it's tomorrow. There's a panel, building a health literacy statewide coalition, lessons learned from 5 states. And I would also say statewide health literacy coalitions are as different as the states themselves. And I'm actually really looking forward to that session to hear from other leaders, including some of them in Pennsylvania's bordering states, about their initiatives. So if you're interested in this, go check out the agenda and find that session, because I think that's going to be really instructive and providing, again, kind of that breadth of what statewide health literacy activity really looks like. So with that, I think I will move over to see if there are any questions for me in the chat. Thanks. Okay, so I'm looking at the questions here. I see a question says, are there specific tips you suggest to the elderly community to help them navigate complex healthcare discussions? This is a great question. This is a really challenging question. And I would say that to elaborate a little bit more on what we did with our peer education program, we use the Ask Me 3 model. And so Ask Me 3 encourages patients to ask three main questions with every healthcare encounter. So what is my main problem? What do I need to do? And why do I need to do that? And so what we found was that our seniors found those questions to be very useful. And the peer education training gave them an opportunity to practice using those questions through scenarios as well. So they got to practice that. But more than just those specific questions, just like that mindset shift of being allowed to ask questions, creating that permission structure to engage in a conversation, that your physician or your provider is not on a pedestal, that you are an expert on yourself. You are also bringing expertise on yourself to this healthcare encounter. I think that was the thing that we heard the most positive feedback on. It was just, again, creating that permission structure to even open up a conversation, to even speak up without being embarrassed or feeling shame if there was something that was misunderstood. So again, the way that we did it was using that Ask Me 3 framework, which is a very solid framework. But I think any of sort of the question asking frameworks that exist out there, like I think AHRQ has one, I think any of those would be a very solid foundation for reaching seniors and encouraging them to play an active and empowered role in their health. And then we have another question here that is the PA Health Literacy Coalition involved with the Philadelphia Community Engagement Alliance against COVID-19? Thank you for that question. We are not. I see you have the website here and would love to connect with you offline about that group. I think there's probably a lot of alignment with not just our health literacy initiatives, but some of HCIF's initiatives overall. So maybe I will plan to follow up with you offline. And I see Karen, thanks, great presentation. Thanks for the shout out to tomorrow's statewide collaborative session. I'm very much looking forward to your session tomorrow. So yes, again, just to once again shout out that panel session where you can hear more from other statewide coalitions. That's great. Let's see, I see training tips for initiating conversations on health literacy to a potentially resistive healthcare professional audience. Oof, that's a tough one. I think that one thing that we pay attention to is making sure that we're sending the right trainer and the right messenger. I think that is a necessary but not always sufficient component to reaching a resistant audience. I think that there are provider audiences where, for example, we feel like a physician might be the most effective trainer. And so we sort of try to match that up. Who's going to have the credibility with that audience? Who can speak to their own health literacy journey? I think that's really helpful too. If you can have someone who says, I was doing things this way for a long time, and then this was what made me change my practice and the way that I was thinking about or doing things. I know Dr. Plum, one of our subject matter expertise is really great about that, especially when it comes to physician audiences. So, finding the right trainer, I think, is important. Finding the right format for the training, making sure that that matches the needs of the audience, making sure that the training topics are tailored to what the audience needs. I think that people really want something actionable. And so we try to make sure that there are always takeaways for the trainings, and just encouraging folks that, you don't have to take a burn it all down approach, right? Like you can take a training and take one practice, like try a new practice with one patient, maybe at the end of the day or before your lunch break or when you have a little more time. And really encouraging that incremental change, I think, is helpful too, to a potentially resistant audience. And I see we have just a comment from Dr. Plum. If we could get 10% of providers to effectively use teach back during encounters, we could advance equity. And agree with that, Dr. Plum. There's another question here. Did you develop your own education materials, or are there standard materials available to education healthcare professionals? So our training materials have evolved over time. I believe the base materials that we were using were from the American Medical Association. So they did a train the trainer specific to physicians and providers. I believe kind of this work started maybe something like 2005, 2007, and they had an entire toolkit around this. And so that was what we used as the base for our training materials. And then, as I said, I think they've evolved a little bit away from that over time, and we've incorporated other elements, but I think that was useful. I think now there's probably a lot more resources out there available that you could use as a baseline and then adapt to meet your audience needs. And then I have a question. Have you thought of providing your trainings, materials, best practice examples to those outside of Pennsylvania for pay as part of a sustainability plan? We have. It's something that we've thought about throughout the years. We've been lucky enough to always have the grant funding to support this, but I think as we shift towards a different funding model, that is something that we are considering, sort of a more fee-for-service model. And, I think it's tough. I feel challenged by that because we've been so lucky to be able to provide these services internally to Pennsylvanians because of the grant. We often don't have to charge. But I think that shift to fee-for-service is something that we're going to be looking at really hard this year. And, hopefully that gives us an opportunity to share what we are doing more widely across the country. And then want to note too, I see Dr. Brower mentioned we've been working to train future nurses, doctors, and pharmacy students. Yes, I think this is a really important point. So as we think about the future, I know Dr. Brower and Dr. Plum have played a huge role in training sort of our future health professions across a lot of different disciplines: nurses, doctors, pharmacy students, OT, PT, basically any health profession you can think of, public health even. And I think what we're hearing from our partners is that they are seeing that, for example, new nurses that are coming in, they know what health literacy is. They are coming out of school with some familiarity of that. There's kind of less of a gap to be filled between like their baseline knowledge and say like competencies or health literacy training that's delivered as part of the organization. So I think that's really encouraging to see that. And I think that that is an area where, we haven't focused on that statewide necessarily. We focused on it a little more regionally. But I think there are some really great opportunities in Pennsylvania and really across the nation to ensure that our fresh new healthcare professionals coming out of school are already receiving these best practices and this information as part of their training. I'm trying to see. I think that at this point, I have covered all of our questions. So just want to thank everyone for sort of joining today. Appreciate you taking the time. And yeah, hope you enjoy the rest of the conference. Thank you so much.